the introduction as well. And also thank you for the work that you've been doing in that field, where a lot of kind of mirroring happens, I think, with data being the center of the focus of attention, I guess, the center of attention. I'm gonna share my screen. Hopefully you're gonna be able to see. So I try to, because I don't, can you see that? You can probably see the full screen.
Yeah, it's perfect. We've got your slides. Yeah.
Perfect. Okay. I don't know what's the background on health economics in the audience, so I'm gonna first start by covering a bit of ground on the type of work that we do, kind of an introductory session, and then I'm gonna give you an example of a more specific example on how we use simulation modeling and data. And so, as as Ron mentioned, I started with economics in the field of economics and econometrics, and then I jumped into health during my PhD. And as you are fully aware, there is a scarcity problem in healthcare resources and an increasing need because of aging and because of us wanting to live longer and having a better quality of life. So the question is how to spend wisely. And in economics, we study choices when allocating scarce resources in a way that satisfies a need that seems to be unlimited. And we're interested in the incentives that drive that allocation. And so we want, as health economists, to inform a decision, to inform an optimal allocation of resources, of healthcare resources, so that we can optimize something. And that something is usually health, and a combination usually of health and quality of life. The thing is, though, that the type of field that we are in draws a lot from another field that's the field of decision analysis. And so because we have, and I think economics and decision analysis are very closely knit, but we have to make decisions under uncertainty, given the data that, first, take an RCT, for example, a clinical trial, for example, limited sample size, limited follow-up time, and we have to make a decision with so much uncertainty as to whether we should be paying for that new therapy or not. So the type of questions that a health economist would be asked to answer range from, for example, what is the economic burden of a given disease, and what is the attributable burden of that disease, and what's the cost of care across different phases of a disease trajectory, or what is the value of investing on a specific technology rather than the broad disease space? What is the value for money of a technology, or the cost effectiveness of the technology, as is so often referred? I think the holy grail question is, how much are we gaining for any any expenditures that we make? How much health are we gaining from that expenditures? Difficult question to answer. Efficiency of healthcare generally beyond the healthcare system as a whole, but like a hospital, a specific unit within a hospital, how efficiently it operates. And another classic is, financial incentives, for example, for physicians. Do they work? Do they change behavior or not? So these are very, very few examples of the things that health economics would try to answer, obviously. But I think what I would like to focus on is the fact that actually health economics it's kind of a pitch for people that they in data science, but it's full of data, and it's full of different types of data that need to be analyzed. So we have patient level data from RCTs. We have data that we don't actually have the patient level data, but we digitally reconstruct from publications. We have hospitalization data, physician visit, prescription, longitudinal or data on all that we recently linked to immigration, employment, education, and tax data. And we also have census and health surveys that all of them have been conveniently, as I said, recently linked and are available for scientists. So it's quite a data-rich field. On top of that, we use literature data that we conduct meta-analysis we're going to refer to. And finally, I think that's also the way I met Monica, actually, was because we use life tables, and we use a lot of demography methods in order to analyze this information. So kind of again, I find it pretty interesting because as a health economist, you're going to dive into regression modeling with all kinds of weird data, skewed, incomplete, censored data, lots of survival analysis, a lot of analysis that is more pertaining to biostatistician work that you will need to be aware of, meta-analysis, and today's talk is going to be a little bit about the causal inference for large observational data bit, which again, when we try to, for example, estimate the attributable cost of the attributable burden of the disease, we try to use causal methods that try to, to get to that kind of specific cost associated with the disease, or caused by the disease, as opposed to associated with the disease. And Bayesian methods are used throughout, and that's why I italize them. Demography, statistics, as I mentioned before, and lastly, this kind of field of decision modeling, which essentially is simulation modeling of the disease, which I'm going to focus today. So if any data PhD students graduating with an interest in data, you could, I mean, it's a total pitch, but like you could consider the field. There's opportunities. So in the context of decision analysis, I mean, we have to balance as health economists between a number of different options and number of different outcomes that they would form a policymaker would form a decision based on these different outcomes. So think of a new treatment, you have multiple options and you have to balance the benefits, the harms, and the cost of that treatment. And how would you do that? And the way that we typically do it is using this kind of simulation models where they act as a tool to synthesize information. So you have a decision model, which is going to be the medium to synthesize information on the probability of the disease, how likely is the disease, or what's the quality of life associated with the disease, or different stages of the disease. Is there a treatment? What's the efficacy of it? What's the adherence level? What are the costs associated with the disease and the treatment itself? What's the risk of future events? With all that kind of you can think of them are synthesized through that model to get an estimate of healthcare and economic outcomes for different options or strategies. And that is supposed to be converted or described in a way that will allow politicians or policymakers to make decisions on. So it has to be also easy to understand and easy to even possibly modify. So another cool thing about the field is that you can see a direct policy implications. A lot of us are involved in both the academic part of it, but also we consult the government in decision making and in our actual work life. So different types of these kind of simulation models. I'm not going to go into detail on what these different types are, but I will essentially focus on the last one, which is what's called a microsimulation, which you can think of it as a simulation of reproducing a hypothetical population, where you follow this population over time and you watch them, this hypothetical population, transition between states, experiencing events, and then you switch something, you switch a lever on and off, say you provide the treatment or you don't provide the treatment on that population, follow them over time, see what happens. So you create this hypothetical population that you can act upon to understand how different, how if you were to modify some of their characteristics, what would happen to their outcomes. So that's an example of such a model that we're building now. That's in psychosis. You have individuals that they can start without psychosis, and then they can have psychosis. They can be stable, or they can have episodes of severe psychotic episodes. These individuals will have their own characteristics and risk factors. And while they are in that psychosis state, they can have cardiovascular events, diabetes, cancer, respiratory diseases, chronic conditions that they can also affect the risk of either another episode or the risk of death. So that is kind of an example of such a schematic of a model like that. So after going very briefly through what these kind of simulation models look like, I'm going to show you how we've used these models in conjunction with administrative data, with large data, to understand what is the clinical and economic burden of COPD, chronic obstructive pulmonary disease in Ontario. And that was, we were thankful to receive funding from the CRRN, which is the Canadian Respiratory Research Network, to do this study. And I'm also very, very thankful on Liz Bond, who is the first author in that paper that we published, who actually did so much of the coding and of the analysis. So I'm going to quickly go through the concept of burden of disease, which is very heterogeneous in its definition, and it's essentially it's defined as the duty, obligation, and expense essentially that the disease creates for society. But it's used and it's used worldwide to characterize the impact of the disease on both health and costs. Generally, it's useful to know what is the burden of disease of a disease, because it can allow policymakers to prioritize. Should we focus on cancer, or should we focus on another disease that maybe has a less of an economic and clinical footprint? and for better or for worse, it has also been used as an advocacy tool. So, but the definition of what burden of disease is heterogeneous in the literature, and but you could say that mortality, morbidity, and quality of life are primarily, it's always there when you're thinking of burden of disease, like if something kills you, or if something causes you to go to the hospital, or if something reduces your ability to enjoy life, probably that is a burden. In addition to that, healthcare costs have been considered as also something that causes like some burden of disease, but and that is often taken into consideration because it is somewhat easier to take into consideration from all the economic impacts that the disease might have. And the most difficult and I guess complex way of capturing the burden of disease is understanding also what's the economic impact outside of healthcare, but on societal impact and say productivity losses and reduced earnings, leisure time, and other kind of indirect costs that that a disease might cause. So there are different methods of estimating healthcare burden, and today I'm actually gonna talk about the methods about using estimating both health and economic burden, but we don't have enough time to go through a lot on the economic side. So a lot of it's going to be health related in the analysis at least. So the thing with some of the diseases is that they have complex disease pathways, and they can have intermediate events that they can affect your risk of experiencing yet another event, or dying. And all these kind of complex patterns and the competing risk nature of some of these patterns have to be addressed in a methodologically sound way. In addition to that, you have time-dependent covariate effects that you also want to address. So the way that the people have done it in the past is that they have broken down essentially the life trajectory of an individual over phases, from the point of diagnosis with a disease to the end of life. And this curve on the right, you would see the curves on the right would indicate kind of how is a usual trajectory of costing over time, of cost over time, where you see that at diagnosis, high costs, over time, you get to a plateau, and right before death, there is this increased cost associated with, excessive hospitalization and, palliative care and maybe some therapies that they would be much more expensive and so on. And this method, when it is pretty commonly used, and what they do, people, is that they break down this early part, the late part, and the plateau, and they estimate the cost. But I think we thought it was rather simplistic, and it's also not really representative of the disease trajectory. It's more of after you look at the data, you kind of define a structure. So the phases and the duration of that phases need to be predefined, and then your estimation of uncertainty, when you want to measure not only what's the burden, but also what is the uncertainty around your estimates of the burden, are not straightforward because of the way that it has been, dissected, essentially the process into smaller steps that they are not easy to put together. And if you want to study subgroups, it's not very easy to do so without methods. It doesn't fit within a counterfactual, causal framework in a way. So if you wanted to study what would happen in the absence of, or if one of the covariates would be modified, then it would not be very straightforward to do so. And other limitations that pushed us to think differently on how to do that. So how to estimate the burden of the disease over time, taking into consideration this kind of time dependency of cost. The other issue is that more and more, if you're in the field of health, you would probably notice that more and more care is becoming personalized, and so therefore you need a way to be able to calculate kind of subgroup specific, if not individual specific trajectories, to be able to inform decision making within specific subgroups. So we wanted to find a solution that would also take this kind of personalized care into consideration and create a structure that could be run for different subgroups and different, smaller groups of individuals. Lastly, this is how kind of administrative data work in practice, where you have individuals like me, that they would be on the left hand here. Then you would have to draft a protocol, and this protocol would have to be sent to an analyst who would run the analysis for you. You wouldn't see the data, unfortunately. You get the results back. You go back to the analyst, you modify the analysis plan, they rerun it. That's super expensive. Then you get the aggregate results, and you end up with writing a manuscript. So to summarize, we had to estimate health-related outcomes like mortality, hospitalization. We wanted to understand costs. We have competing risk problems. We have recurrent event problems. We have people transitioning across multiple states in the COPD space. And we need to incorporate time dependency, allow for potential counterfactuals, and inform future cost-effectiveness studies. We tried to do all that, and while extending the phase of care methods that they have been put in place, while also, of course, having this data access restriction for a good reason, I guess, for privacy concerns, but still a limitation if you want to analyze the data. So we worked it out in the COPD space, which has COPD is defined, or at least the severity of the disease is defined crudely by how frequently you're going to exacerbate. And this exacerbation is essentially leading you to go to the hospital or go to the ED. So we wanted to measure ED visits, emergency department visits, and hospitalizations to understand how the disease progresses over time. And we wanted to do that, as I mentioned, across targeted kind of subgroups. And so we developed, there are some simulation models that are already developed and more that are being developed. And we wanted to make sure that whatever we build is going to be informative for these models. So we wanted to identify subgroups of COPD population that are at increased risk. We wanted to estimate the effect of a smoking cessation intervention. And we wanted to quantify the costs of COPD per groups across time. We had a lot of information from, so first we scanned the literature to understand what can be a risk factor for hospitalization, ED visit, or mortality in COPD populations, so that we can understand what we could incorporate into our model. And these are some of the covariates. These are the covariates that we ended up with. So, your age, your sex, whether you smoke or not, ever smoked or not, whether you live in a rural or an urban setting, your deprivation status, this economic deprivation status, and then how often have you been visiting the ED, or how many times have you been hospitalized in the past, together with comorbidities. These are the data sets that we've used. These were all linked to one kind of larger data set. And one of the important, I guess, bits is that we linked to the Canadian Community Health Survey, which has information about smoking, which is the difficult kind of question to answer with respect to smoking is difficult to smoking information is difficult to find. So this is the overview of how the we'll have time, a little bit of time left. This is the overview of how the structure of what we've put together looks like. So I'm going to walk you through that, I think, section by section, but essentially we create a cohort, then we simulate that cohort, and we produce an output. But I will walk you through that. The code is out on the web if anyone is interested in reproducing it, and we used R for that for us to be able to run all that. So we started with a very simple model where you have someone who is diagnosed with COPD in the community, and they can be hospitalized. They could visit the emergency department and then be hospitalized, and then they can die from the hospital, or they can go back to the community, and they can repeat this exercise many, many times. Okay, so you have recurrent events in the hospital or the ED level, and you have one, like mortality happens only once. So what we used to estimate essentially these arrows indicate transitions from one state to the other. So a concept that's called multi-state modeling, which is essentially an extension of survival analysis into a multivariate space, fits very well with that kind of concept. And so we used a multi-state model where essentially we fit a number of parametric survival regressions. We tried a number of different distributions, and we tried to understand what is the best distribution to use based on a number of criteria, including the AIC, the BAC. We did visual inspections, and we tried to understand through the area under the curve. There is an issue with computational complexity and time dependency in the area under the curve that we came across, especially because our data set was large and our follow-up times were also long. So first, we started by fitting these kind of regression models to understand what is the risk of experiencing an event. ED is not something that happens. We didn't use a survival analysis model for the visits to the ED because we assume that they're transient. I mean, you go in and out in the broad spectrum of your life. Stay in the ED is so small that it's not worth explicitly kind of modeling time. And then we have a cost per. We can extract from the administrative data set a healthcare cost per 30 days per state. So for everyone who was in hospital, we had an estimate of the cost that for the first 30 days, the next 30 days, and so on. For the same for those that are in the community, and for the ED visits, we explicitly costed out the ED visits were part of the we included it within our cost of being in the community. So in a way, ED was modeled so that it can increase your risk of hospitalization, but any costs associated with visiting the ED were folded into the cost of being in the community, simply because the ED is such a short stay. And so we tried to model the cost per state per time, and we used essentially a two-part model because we have a lot of zeros. We would have a lot of zeros. There would be 30-day intervals where you wouldn't visit the hospital or you wouldn't visit any physician, so you wouldn't have any cost to account for. And we tried to model the complete follow-up with a binomial GLMM. Essentially, we fitted, and then we fitted gamma models for GLM gamma with and log normal models for the understanding the cost of if you were to incur cost, what would be that cost? And we tried to capture the kind of time dependency of that within a given state. And again, we tried to validate as much as we could internally and externally somewhat these estimates of cost that we extracted. Now, this is the regression modeling part on the data. The other thing we did is that we took our data, and we cannot access that data, if you remember, and also we don't have personal access to the data, but also that simulation models that we're building require a synthetic cohort or a hypothetical set of individuals that they are going to run through the model. So in order for us to recreate that, to create that cohorts, we essentially tried to understand their joint distribution through a series of chain regression equations. So we reconstructed the original data in a way that A was not violating any privacy associated with accessing that data. but also in a way that would allow us to switch on and off some covariates to understand what the impact of those covariates are on the outcome. So we call them counterfactual cohorts. And you can imagine, for example, a cohort that is essentially describing the average COPD, or like a population of COPD patients in Ontario that are non-smokers, or that they're smokers. And then we could switch their smoking status to be former smokers instead of current smokers, and understand what is the smoking specific effect of, at least that was our premise, to understand what's the smoking specific effect on the outcomes, given that we had information about who was a current smoker, who was a former smoker, and who was a never smoker. And we also did that in a subgroup level, where we say we're going to subgroup the smokers versus the non-smokers versus the never smokers. And you can imagine that the characteristics, the rest of the characteristics, if you're a smoker, you have a whole different covariate, like comorbidity set, than if you were a never smoker. So these people are going to look very different. So we build our models, we build our cohorts, we feed them into our simulation, we create the synthetic cohorts jointly, we create an output that we have to summarize. But another thing we need to do is we need to propagate the uncertainty of all that little steps to the output. And so to do that, we essentially rely on a Monte Carlo simulation process, where we go back and we extract all the uncertainty from the models through their various covariance matrices. We sample from them, and we feed a new data set. We feed a new cohort, and we feed a new set of regression output into our model to get another curve into our hazards and survival and whatever outcome we have. So the health outcomes, we estimated mean cumulative counts for the average number of events of interest, and a cumulative instance function, a cumulative instance for the absorbing states. And for the cost, we estimated average total cost per state and unit of time, and average overall daily cost and survivor costs. And this is kind of an example on the right of how this cumulative count would look like. Okay, as I mentioned, we didn't have access to the data. So what we did is we created a simulated data set to match the real data. We wrote the R code, we ran it on the simulated data set, physically email it to the analyst at ICES, which is the organization, the custodian of the data. We waited for an error to pop up, sent to us back for debugging, back again, adjust and repeat. So that was a bit of an annoying process, but that was also a constraint on some of the things that you might, like, if you think, why didn't you validate that, or why didn't you test that? You have to remember that we didn't have access, so we were limited to the stuff that we could possibly check, model dependence and all that. Like, feasible, yes, but also funding was limited. So we tried to, as much as we can, validate. So we looked at the internal validity by looking at what the model survival estimates were compared to what the observed estimates were from survival, as well as total costs against the administrative data costs that we estimated versus what we were given, essentially. And external validity, we found some estimates from an older report about the length of stay for someone who has COPD in after hospitalization, and we tried to compare it against that. We did not do bootstrap and cross-validation for due to computational complexity and the fact that we would have to explain that to the analyst, and we couldn't. So again, you can. Oh, sorry, why am I jumping around? Okay, so we started with, like, the ICS records hold 10 million COPD patients. Out of those, 800,000 were diagnosed around the time that we were interested, from 2001, 2014. We had to exclude the majority of those because we didn't have access to their smoking information. And so the final cohort was 14,000 individuals that they were followed for 14 years. And you can see their characteristics on the right, and you can see the vast majority of COPD. the COPD patients have either been smoking or are actively smoking. It's a disease that is very prevalent among smokers. And they had a comorbidity that was kind of characteristic of that population and that age. So this is on the right-hand side is the actual data. On the left-hand side is the simulated data or our model outcomes. So we were happy to see that we could kind of recreate. This is a survival curve, and you can see that there's survival over time. Like after 14 years, about 60% of the individuals would be alive in our model, and the same was happening in our original data. So that was like our first kind of, okay, what we're doing is kind of reasonable. And we see that the average hospitalizations was about half, and think of these are being, and these are like COPD related. So we broke, I forgot to mention that, but we broke hospitalizations into COPD related and non-COPD related. If you were to, have a heart attack, that would not count as your COPD related hospitalization. So essentially through that process of estimating a counterfactual, this is the three groups. First of all, like these are without creating any counterfactual cohorts. Imagine that you run your simulation cohort, you run your synthetic cohort, and then you break your results into three categories. Crudely speaking, the never smokers, the former smokers, and the current smokers. And what you can see from the top left is that current smokers are actually more likely to survive than never or former smokers, which was initially was like, if you're not a clinician, you're like, okay, that's interesting. Why are current smokers more likely to survive than people that they are have never smoked? But to be diagnosed with COPD and never have smoked, that would have put you into an older age category, or with a different comorbidity profile that could put you at a risk of dying earlier. So that would explain the differences across these curves. And if you were to look at the mean cumulative count of COPD-related visits, you would see there that despite the fact that these individuals would live longer, the smokers, they would experience a lot of hospitalization and a lot of ED visits compared to never smokers. So, and then that's the top row. If you look at the bottom row, is the counterfactual example. So now we took our current smokers and we said, okay, what if we had an intervention that would switch them from current smokers to former smokers? How much benefit would that be? What would be the benefit with respect to life expectancy and reduction on ED visits and hospitalizations? And you can see that now the model behaves as you would expect to, where you would see the survival gains for someone who switches from current smoker to former indicate going into in the direction that you would have expected. And the same holds true for the current to former smoker with respect to ED visits and hospitalizations. So essentially by using what we've just very quickly went through, you could consider estimating a specific effect that's an effect that's specific to one of your covariates in your model by using simulation modeling and this kind of number of regressions that would inform your simulation. And you can report that effect in a different way. You can have absolute differences or relative differences as your kind of reported scale. And because you're simulating it, then essentially you can take your simulated output and present it in a way that is more better understand from the or whoever is the policymaker. So we try to validate internally do we get from the model an estimate, for example, of the mortality for former smokers. Actually, I can't recall. Is that the rate of hospitalization? I can't recall what the unit is. I'm sorry, but I think this is the number of hospitalizations per individual, where we saw 0.5 hospitalizations per individual, as opposed to 0.54 for our model, which was super close. And for smokers, for current smokers, that was much higher. But again, relatively close to each other, model versus real world. And the external validation part, we compared our estimate of length of stay for hospitalization, which is about 10 days, 10.17 days from our model, against the 10-day average that was reported in this study that I mentioned before, an older study. So that was also comforting with respect to at least getting ballpark similar estimates from our model and what the literature has indicated. As I mentioned, cross-validation was computationally challenging, given also the limitations in data access. So kind of this is a brief overview on how you could use administrative data and simulation modeling to estimate the burden of the disease on survival or on hospitalization and emergency department visits, which are typically considered as some of the indicators of burden. And as I said, there is a costing piece which I took it out for the sake of time. And there are a ton of limitations, including the fact that we were using survey data and smoking status is self-reported and also cross-sectional, somewhat cross-sectional. I mean, you know when they stopped or when they started smoking, but it's self-reported. And computational power was limiting on the simulation side. I think things are much better if we could use a supercomputer, which we have at SickKids, but because the data sit not at SickKids, we couldn't. And there's an incredible cost that we didn't anticipate on conducting the research, because all that research had to happen at a different place than where we usually work. So concluding, you can use that kind of simulation modeling to understand burden of disease and quantify the impact that specific covariates have on resource use, survival, and other outcomes, including costs. You could then subgroup. We subgrouped as an we subgroup on smoking so that we can show the usefulness of it, but you could think of subgrouping on different covariates to see what is the burden in different subpopulations. And we think that this method kind of is a more natural and statistically sound way of analyzing these phases, as opposed to the random phase of care. You break the trajectory into phases that they mean something. You were in hospital and that's why you were more expensive, or you were in the AD and so on. That's why you were at high risk of dying. And one last note was that, first of all, when we thought about it, we're really happy that we found something novel. And then, of course, you look at the literature and someone else has thought of that before you. So there was a paper about parametric multi-state survival modeling and how you can use it for that purpose, that actually ended up being very useful, because we modified our approach we found it halfway. So we used a lot of the information that they provided, and it's a very useful paper if you want to understand more of what we did. The other thing that we realized is that, again, we thought, oh, that's a great thing for causal inference, and we haven't really, this field of decision modeling and simulation modeling does not really, I don't know, sometimes we're a bit distinct from econometrics and so, and we're like, oh, you could use it for causal inference. And of course, as we started talking with people in the causal inference space, there's a method called parametric G-formula, which there's a simulation version of the parametric G-formula that looks very similar to what we've done. So we haven't really, we might have reinvented the wheel in some sense. But again, in the context that we used it, it hasn't really been, in the health economic context, I don't think that that a lot of people have used it before, but still, we learned a lot in the process as well. So that's it. Thank you very much for giving the space to present, and I'm happy to discuss.
Thanks, mate. That was really interesting. I think if you're reinventing the wheel of James Robbins, you're sort of like doing something right? Like it's always disappointing to find these things halfway through or whatever, but at least it's good to know that you're not reinventing something that somebody's failed at, right? And it's a big paper.
Yeah, and I think it's I mean, it happened a lot in the field of quantitative methods, that people have come to the same conclusion from different angles. So.
Yeah, I'll stop recording. We'll take some questions.